Definition is defined as acute inflammation of the mucoperiosteal lining of the middle cleft. Now, what is middle cleft? It consists of eustachian tube, middle ear proper, adductus ad antrum, mastoid antrum, and mastoid ear cell system. And the infection is limited to the mucoperiosteal lining. And infection does not penetrate the mucoperiosteal lining, that is underlying the bone. Then it leads to complication. Types of reaction depends on what are the factors, virulence of the positive organism, resistance of the host, and promptness on adequate treatment. Severity of the clinical manifestation depends on the degree of pneumatization of mastoid. What are the type of mastoid? Pneumatic, sclerotic, and diploic. In sclerotic mastoid, there is no ear cell except mastoid antrum. Mastoid antrum is the persistent permanent mastoid ear cell. It is always present. Antrum is always present. Why severity is much more in pneumatic type of mastoid? There is more surface area of mucoperiosteum lining. So, infection is more severe in case of pneumatic type of mastoid infection. And allergy and immunity of the child is not yet developed. They are depend on the passive immunity due to recurrent infection in childhood. Children are gradually developing their immunity. So, in case of children, immunity is very less. Both sex are equally involved. What are the predisposing factors? URTI, that is upper respiratory tract infection, common cold and influenza, adenoid enlargement. Adenoid is the main thing in case of children. In case of children, adenoid is nothing but a aggregation of lymphoid tissue in the nasopharynx. And in case of children, adenoid is enlarged generally. Acute exanthematous fever, any nasopharyngeal tumor, polyp or nasopharyngeal packing. In PNS packing, there is chance of infection in nasopharynx, giving rise to nasopharyngitis, and infection goes to the middle ear through eustachian tube. Chronic sinusitis and cleft palate. Generally, cleft palate is associated with pharyngotympanic dysfunction, and they are very prone to recurrent acute otitis media. What are the risk factors? Bottle feeding in case of children, allergy, overcrowding, poor socioeconomical status, smoking by family members at home, sibling having otitis media, viral infections in the family, hereditary and genetic factors. Other associated disease, they are cystic fibrosis, immunodeficiency, Down syndrome, ciliary dyskinesia, there is Katayana syndrome. Then bacteriology. It is generally gram-positive pyogenic bacteria, gram-positive cocci, and rarely gram-positive bacilli. Among the cocci, Staph aureus, Streptoneumoniae, Moraxella catarrhalis, Haemophilus influenzae, Escherichia coli, bacteroids, and other gram-negative organisms. Route of infection. There is through the lumen of the eustachian tube, submucosal peritubal lymphatics. Peritubal means around the tube, the lymphatics, through the lymphatics, infection goes to the middle ear, and through the tympanic membrane perforation. A COCM with shape type can have an attack of acute attack of otitis media. Bloodborne is rare. Now, pathogenesis and symptomatology at different stages. There are 5 stages of acute otitis media. Pathogenesis is the course of the disease is divided into 5 stages. First stage is stage of tubal occlusion. What happens in primary stage? They occur edema and hyperemia of the nasopharynx and eustachian tube. As a result, tubal blockage is there, and in middle ear air is absorbed, and there is negative pressure in the middle ear, and there is some effusion but not clinically detectable. What are the clinical features in tubal occlusion? Just fullness of the ear, otalgia, no fever. Autophony means patient can hear her voice more in the affected ear. What are the signs? Tympanic membrane is retracted. How will you diagnose clinically the retraction of the tympanic membrane? They are shortening of the handle of malleus, because handle of malleus rotate posteriorly and medially, and there is force shortening of the handle of malleus, and there is more prominent lateral process of the malleus, and there is loss of right reflex and mild conductive hearing loss, and you will get Rene negative in 256 and 512 Hz frequency tuning fork. These two tuning forks give result of negative Rene. This is pre-suppuration or second stage. Prolonged tubal occlusion, that is invasion of the pathogenic organism. Mucosal hyperemia and inflammatory exudate comes into the middle ear, and there is symptoms is more increased, throbbing pain which can awake the patient from sleep, and there is tinnitus, which is bubbling sound in the ear. Deafness increases, but child cannot notice it because of severe pain. Constitutional symptoms is increased due to absorption of the bacterial toxins. There is high degree of fever, malaise, and child is restless. Signs: pars tensa is congested, bulged out with cartwheel appearance. This cartwheel appearance is due to peripheral blood vessels coming to the umbo and handle of blood vessel along the handle of malleus, and tympanic membrane looks like a cartwheel. Later, the whole tympanic membrane bulge and light reflex is lost, and whole TM including pars flaccida get uniformly congested, and deafness is increased, and there is serial tuning fork test, that is, it is also negative in 1024 Hz frequency tuning fork. 256, 512 and 1025, all three tuning fork tests comes to be negative. Negative reading means there is conductive hearing loss. This is the picture of second stage of tympanic membrane. Then stage of suppuration. Now suppuration means there is accumulation of pus. The pus is forming in the middle ear as well as the mastoid ear cells. TM start bulging. Symptoms: excruciating pain, pain increase, deafness is also increased, temperature increase, headache, and there may be vomiting, convulsion and diarrhea. What are the signs? TM appears red, bulge with loss of all landmarks. All landmarks are lost. And there is point of appearance of a point of suppuration. There is center which appear like a yellow nipple. This is the point where perforation will occur, and perforation occurs at the center of the pars tensa. This portion is more vulnerable to ischemic necrosis. The central part of the tympanic membrane is more vulnerable to necrosis. There is small amount of there is small, when there is light inside the, if you put light inside the tympanic membrane, as there is small perforation, pus come out like a pulsating nature, and your light will be like pulsating, and this is called lighthouse sign. This type of recurrent off and light is called lighthouse sign. The TM perforation is seen after cleaning the pus. As pus accumulate into the deep part of the canal, you have to clean the pus to see the perforation, and it is located at the pars tensa. It is central perforation, always due to non-healing of acute otitis media. The end result of non-healing of acute otitis media gives rise to a central perforation. Then stage of resolution. After perforation and discharge of pus, what happened? All symptoms are gone. There is no symptom of pain, fullness of air, and constitutional symptom is over. There is blood and air discharge and pus coming under pressure and synchronizing with the heartbeat and arterial dilatation. With treatment, the discharge comes out from the middle ear, infection is controlled. Perforation may heal spontaneously. If it responds with the treatment, perforation may heal automatically. Perforation or TM may not heal or remain without any dry stage. A middle ear pathology heals completely in majority of cases. Neonates' irritability of feeding difficulties may be the only indication of septic focus. There may be failure of resistance. Why there is failure? Lack of resistance of the patient. This is the host factor. The host resistance is less, inadequate treatment, and drug resistance. These are the cause of failure. Now, stage of complication. It depends on the virulence of the organism. If very highly virulent organism is there, there is chance of complication. And resistance of the patient is low and treatment is poor. A complication in the second week generally occur and infectious signs and symptoms reappear. Infection spread to the neighboring structure beyond the limit of mucoperiosteal lining. There occurs demineralization of the safety between the ear cells. Mastoid ear cells are honeycomb-like ear cells with multiple safety. These safety are destroyed, due to demineralization of the safety. There is all the loss of all the ear cells, giving rise to one pus-filled cavity. That is called coalescence mastoiditis. Edema and granulation block the aretas. That is the pathogenesis of the coalescence mastoiditis. And plaque collect in the mastoid antrum under tension. How to diagnose a case of otitis media? Otitis media, clinical diagnosis from the history. History is important. That is comes from the there is always a history of upper respiratory tract infection in case of child. And sudden onset of symptoms and signs infective. The TM and condition of the middle ear mucosa, that is otoscopy. Otoscopy করে কি দেখতে পাবে? কি দেখতে পাবে? If the patient comes in stage 1, what will you see? Clinical diagnosis. How will you diagnose a case of stage 1, stage 2, stage 3, stage 4? I already tell the different stages. Patient may come in any stage. So how you diagnose the case with staging? If it comes with stage 2, there will be cartwheel congestion. If it is stage 3, there is only bulging with diffuse congestion. If it is stage 4, there is pinpoint perforation with pulsatile. There is lighthouse sign. In case of stage 1, there is foreshortening of the handle of malleus, prominent lateral process of the malleus. So you can diagnose clinically the stage of acute otitis media. Then tuning fork. In case of stage 1, there is mild conductive hearing loss. Stage 2, in 2 frequency it will be really negative. And stage 4, more conductive loss, 3 tuning fork negative. So you can diagnose the stage clinically. CT scan and temporal bone is indicated only in refractory case. যেখানে তোমার coalescent mastoiditis, if there is any complication you apprehend, you have to go for CT scan. And if there is a patient comes with stage 4 not responding, you have to go for a pus culture sensitivity of the discharge. Okay. And treatment. What are the aim of the treatment? control of infection, to give symptomatic relief and patency of the sputum tube, because your infection goes through the sputum tube. There is something wrong in the nasopharynx. So, antibiotic will control the infection, and you should give some decongestant nasal drop. Particularly, you feel the head, xylometry, oxymetry, and put on the lateral wall of the right and wait for some time. So, drop will gravitate to the nasopharynx near the sputum tube. তোমাকে sputum tube পৌঁছতে হবে তো ড্রপটা, এরকম করে দিলে হবে না কিন্তু। There is a particular position of putting the drop so that the drop can go into the opening of the sputum tube. Symptoms: rest, sedation, analgesic, dry local heat to reduce pain. Antibiotic. What antibiotic we give? There is broad spectrum antibiotic, co-amoxiclav, dose 80 to 90 milligram per kg per day, amoxicillin component, it is a combined drug, and clavulanic acid is 6.4 milligram per kg body weight. Oral ciprofloxacin axetil 30 milligram per milligram per day. Then ceftriaxone sodium intramuscular 50 milligram per kg in 3 consecutive days. These are the antibiotics used in acute otitis media. Nasal decongestant, already I told you. Symptomatic decongestant like pseudoephedrine. Local ear drop. Before perforation, there is no drop, no effect. After perforation, antibiotic drop like ufloxacin, ciprofloxacin. If there is perforation, then only we prescribe the drop. Otherwise, there is no use of drop. There is no drop. Okay. Oral toileting, if there is discharge after perforation, we have to clean and mop the drop under microscope. Surgery. What surgery? Myringotomy is active surgery, myringotomy in case of acute otitis media. What is myringotomy? Tomy means whole and close. Ostomy মানে হচ্ছে পার্মানেন্ট, মাইরিঙ্গোটমি মাইরিঙ্গোস্টমি, যেমন কোলোস্টমি হয় পার্মানেন্ট ওপেন, সেরকম মাইরিঙ্গোটমি জাস্ট ইনসাইজ দি tympanic membrane to drain out the pus, to reduce the excessive tension of the pus. When TM is bulged and about to rupture, তখনই করতে হবে, ফুটো হয়ে গেলে করতে হবে। এটা কেন করে? To reduce the loss of area of tympanic membrane. If you select by myringotomy and drain out the pus, tympanic membrane loss will be there, not there. Pus is coming through the tiny perforation, still the patient not relieved by pain and drainage is insufficient. If there is very tiny perforation, you have to deliberately increase the hole by incising the tympanic membrane so that remnant pus will come out. It is to be recommended that delay in myringotomy may lead to large type of problem. I already told you, myringotomy হচ্ছে তোমার selective drainage of the pus. Cortical mastoidectomy কখন করবে? When there is coalescence mastoiditis. I already told you there is complication, coalescence mastoiditis. তার ইন্ডিকেশন হচ্ছে cortical mastoidectomy. অপারেশন করতে হবে. You have remove all the air cells, clean up all the air cells. And myringotomy usually done under GA. There is two type of incision in the myringotomy. Pus tensa and pus flaccida তোমরা জানো. Pus tensa and again divided into 4 quadrants: anterosuperior, anteroinferior, posterior-superior, posterior-inferior. In acute otitis media, the posterior-inferior part তোমার করা হয়, posterior-inferior part of the pus tensa, and it is curvilinear incision, sickle 7 incision. Why? Because it is the most dependent part, and you cut the tympanic membrane curvilinearly, there will cut off radial fibers of the fibrous coat of the tympanic membrane. Fibrous coat কি আছে? Circular fiber, radial fiber. মেডিকেল কোডটা পড়েছো? tympanic membrane স্ট্রাকচার পড়ে দেখবে, ও লেখা আছে। আর অ্যান্টেরো ইনফিরিয়র কখন করা হয়? ওয়েবিং, ওটাইটিস মিডিয়া উইথ ইফিউশন। ওটাইটিস মিডিয়া অফ দি ইফিউশন, সাইট অফ মাইরিঙ্গোটমি, শর্ট নোট আছে কিন্তু মাইরিঙ্গোটমি। হ্যাঁ, ইট ইজ রেডিয়াল ইনসিশন। ইট ইজ রেডিয়াল ইনসিশন কেন করা হয়? বা দেয়ার ইজ less migration of the epithelium of the tympanic membrane. Migration খুব slow migration এর জন্য in case of auditory media with diffusion, we put a grommet tube. What is grommet tube? This ventilation tube to ventilate the middle air. The grommet tube. Complication. What are the complication of myringotomy? Loss of taste. Loss of taste due to injury to the cauda tympani nerve. Ossicular damage. There may be ossicular damage. There may be hemorrhage in the tympanic middle ear cavity, that is called hemotympanum. If there is anomalous high jugular bulb, you can injure the jugular bulb. Okay. Otitis media হয়ে গেল। Any question? Classification: congenital, inflammatory, reactive, trauma and tumor. Okay. Congenital swelling of the pinna, preauricular sinus, coloral fistula, congenital anomaly of pinna, atresia of the external canal, congenital tumors of the external ear. Preauricular sinus. There is any synonym? Preauricular sinus, preauricular tract, helical fistula, preauricular cyst. There are different names. It is formed. How it is formed? Due to incomplete fusion of the hillocks as a result of ectodermal infolding of the fusion line forming the tract. External auditory canal, pinna, how it is developed? There is 6 hillocks. These hillocks are nothing but mesodermal element of the embryonic layers. There is elevation of behind the central pit. There is 3 posterior, 3 anterior. If there is anomaly in fusion, that can give rise to ectodermal infolding inside, giving rise to the preauricular tract. This may be isolated ectodermal infolding. It is considered as an incomplete closure of the dorsal part of the first branchial groove. There is some autosomal dominant inheritance due to chromosomal 8q11 is responsible. Clinical features of preauricular sinus. Clinical feature is seen as a small pit along the anterior margin of the ascending limb of helix. The ascending limb of helix. Common হচ্ছে সামনের দিকে থাকে। The tract usually blend with the pericardium. Tract is always attached to the pericardium of the pinna. Sinus tract usually lies superior and lateral to the facial nerve. It is always lateral to the facial nerve. Sebaceous subcutaneous cyst formation may occur due to closure of the opening. If it is closed in the opening, there may be cyst formation, and if it is infected, we lead to preauricular abscess. Management is complete removal of the tract. If there is any remnant left, it gives rise to recurrence. Other congenital condition which involve the external ear: congenital swelling of the pinna, dermoid, hemangioma, lymphangioma, coloral fistula. It is also a fistula. It is anomaly in the first branchial cleft. One opening lies on the floor of the external canal. Floor opening ta thake, floor. close to the another opening lies angle of the behind the angle of the mandible নিচের দিকে থাকে along the anterior border of the sternocleidomastoid. It is difficult to remove because of the it passes through the facial nerve, the parotid part of the facial nerve. The chance of facial palsy is high when you remove the coloral fistula. Congenital anomaly of the pinna. Anotia means no ear, microtia means small ear, or malleotia means deformed pinna. It is feature Collins syndrome. First and second branchial are deformity. Rare congenital disorder, failure of canalization of the first branchial cleft, bony arthritic plate may be present at the level of eardrum, associated with the ossicular chain malformation. Inflammatory condition of pinna. There are erysipelas, perichondritis, pericondial abscess, oral sarcoma. Different type of skin diseases also common like impetigo, boils, furunculosis. Furunculosis is a very common thing in external ear pathology. What is erysipelas? It is due to Streptococcus hemolyticus infection. Bacteria very important. Streptococcus hemolyticus infection of the pinna. Pinna appear reddish and edematous. Systemic symptoms are also common. Periconditis of the pinna. The inflammation of the pericondial lining of the pinna can also follow trauma of the ear. Pinna is enlarged, tender and hot. If not treated, giving rise to a deformed external pinna. This is called cauliflower ear, deformed pinna. Furunculosis is very common. It is due to staphylococcal infection. Bacteria is Staphylococcus aureus of the hair follicle. So, furunculosis is always in the cartilaginous part of the external auditory canal because deep part has got no hair follicle. It is always in the hair. It is very painful condition because there is no subcutaneous tissue. And it is directly adherent to the pericondium. Tragal sign is positive, pressure on the tragal is painful. If furuncule is located on the anterior wall of the canal, if you push the tragus, it will be very tender. If it is in the behind the posterior wall of the canal, if the furuncule is located, if you press the pinna behind, it will be tender. If you the floor of the canal, you put the inferior part of the canal, it will be tender. So, by tender point, you can locate the furuncle which wall is involved. Tragal sign positive. Management includes antibiotic, anti-inflammatory drug. Diabetes should be ruled out. Inflammatory condition of the pinna. Continue. Malignant otitis externa. It is not a malignant disease. It is an inflammatory disease with a low compromised immunity or uncontrolled diabetic patient. The severe form of otitis externa. It is one kind of otitis externa caused by Pseudomonas. Bacteria is different. Here bacteria is Pseudomonas poisoninus. There is extensive destruction of the adjacent tissue. Facial palsy also may occur. Skull base involvement, osteitis in neglected cases. There is uncontrolled diabetes or immunocompromised. Already told you. Otomycosis. Otomycosis is a fungal infection of the external canal. Aspergilla group of fungus. There are two types, nigra and alba. That is black fungus and white fungus. Clinical features are irritation, itching, dull pain, discharge. Where discharge is watery discharge. Discharge type is watery. blockage of the fungal debris leading to diminished hearing. Fungal debris can block your ear canal, giving rise to conductive hearing loss. Management, it is keeping the ear dry because moisture helps to grow the fungus. Always moisture is to be removed. Removal of the fungal mass and antifungal ear drop like clotrimazole or miconazole. These two are used for as a ear drop. Anti-inflammatory drug to reduce the pain and inflammation. Ramsey-Hunt syndrome is caused by herpes zoster virus. There is blister formation in the extra-auditory canal, otolaryngology and lower motor neuron type of facial palsy. Because geniculate herpes বলে geniculate ganglia আছে না facial nerve affect that ganglia giving rise to facial palsy. Herpetic vesicle seen in the external canal. Reactive condition like eczema cottage external, seborrheic cottage external and neurodermatitis. There are reactive condition, traumatic condition like hematoma, frostbite, pseudocyst. And neoplastic lesions. Neoplastic exostosis. Exostosis are nothing but bony elevation of the deep part of the external canal. There are usually multiple in number. When signal it arises from the bone and cartilage junction. It is associated with swimming. যারা সুইমিং করে বেশি তাদের বেশি হয়. According to some authority, the bole much enlargement in size cause generally asymptomatic, but if it is very enlarged and occluding the external canal totally, then it gives rise to conductive hearing loss. And there is deform of the external canal, giving rise to self-cleansing mechanism of the skin of the canal, giving rise to accumulation of debris, giving rise to infection and collection of the inside the canal. Surgery is the treatment to remove the osteoma by drilling or by gouge. Adenoma, external canal arising from the sebaceous gland and in the cartilaginous part of the canal, because sebaceous gland lies in the cartilaginous part. Ceruminoma is also arising from ceruminous gland of the external canal cartilaginous part. Malignant lesion in the external canal, basal cell carcinoma, squamous cell carcinoma, these two types of carcinoma can occur in case of external canal. It is malignant melanoma, exophytic black lesion, generally occurs in the pinna with a highly malignant tumor. Extensive surgery is necessary. Some non-neoplastic condition. First, cerumen or wax. What is cerumen? Accumulation of ceruminous gland. What are the components? First, secretion of the ceruminous gland. Second is desquamated debris, that is from the canal skin, and dust particles from outside. All the three combine to form cerumen. The skin covering the outer part of the canal has special type of gland that produces the earwax. The purpose of the wax to keep, it is a protective function. Wax has a protective function. It is not a disease. Remind it. The natural phenomena. Wax is a protective action to prevent any particle or debris to dust to go inside the eardrum. This may be dry, automatically fall out, and if you push the wax, it may go to the deep part of the canal. You cannot remove it by তোমার ওই কি বলে জনসন বার্ড, সব জনসন বার্ড লাগায় না, জনসন বার্ড দিলে কি হবে ঢুকে যাবে ভেতরে, লাভ হয় না। partial hearing loss giving rise to partial hearing loss may probably cause. What may cause tinnitus, very noise in the ear because it irritates the tympanic membrane giving rise to tinnitus. Earache is common if it is impacted or infected. Wax may be infected giving rise to pain, and if it is impacted giving rise to pain. Fullness of the ear and sensation of the ear plug due to no gap inside. Keratosis obturance is a different thing. You can go to foreign body, can be animate or inanimate. Foreign body in the canal. This is keloid of the external pinna due to ear picking or minor surgery, post-operative scar giving rise to this type of keloid. The keratosis obturance, it is due to accumulation of desquamated keratin of the external ear and get infected. If it is get infected, it expand the external canal. Such accumulation is due to abnormal epithelial migration. There are two types, inflammatory type, silent type, free type. Primary auditory canal cholesteatoma due to trauma in the bony part of the canal. Keratosis obturance, otalgia, conductive hearing loss, there are symptoms associated that হয়ে গেল মোটামুটি। এবার সেরুমেনের ম্যানেজমেন্টটা বলে দিই, খুব কমন জিনিসগুলো ম্যানেজমেন্ট বলে দিই। এক্সটার্নাল ইয়ারের কমনেস্ট হচ্ছে ওটাইটিস এক্সটার্না। ওটাইটিস এক্সটার্না আর টু টাইপ, localized or diffuse. Localized is called auriculosis, যেটা আগে বললাম, and diffuse is there is edematous canal skin. Canal become very narrow. You cannot see the tympanic membrane. Whole skin is edematous and swollen. It is called diffuse otitis externa. কিন্তু ফারাঙ্কুলে একটা ওয়ালে হবে, ঠিক আছে। ম্যানেজমেন্ট কি হবে? Packing. We pack the canal by antibiotic soaked cotton wick. প্রেসার দিয়ে ওটাকে ক্যানালটাকে প্রেসার দিয়ে রেখে দিতে হবে। If you pack the canal properly, ম্যাজিকের মতো কাজ হবে। Pain will be very much reduced. Why? Pain is due to accumulation of pus deep to the skin, but there is no subcutaneous tissue, so exudate cannot be spread out. There is maximum stretching of the nerve ending, of sensory nerve ending, giving rise to severe pain, furuncle. So if you give pressure, counter pressure to reduce the stretching, the pressure will be magically reduced. So packing is very important with cotton soaked antibiotic wick. Then you have to give, as it is Staphylococcus aureus, you have to give proper antibiotic. তারপরে সে ভালো কাজ করে কি? What antibiotic works better in Staph aureus? Cefuroxime axityl, linezolid. এই দুটো হচ্ছে বেস্ট এগেনস্ট স্ট্যাফাইলোককাস। ফারাঙ্কুলোসিস বললাম, আর কি আর কমন হচ্ছে সেরুমেন। সেরুমেন কি করে ম্যানেজমেন্ট করবে? সেরুমেনের ম্যানেজমেন্ট, if it is impacted, you have to give some wax solvent, 7% sodium bicarbonate, to soften the wax, and then you syringe out the wax. Syringing procedure-টা জিজ্ঞেস করবে, how you syringe the ear? Metallic oral syringe instrument ধরিয়ে দেবে, ধরে জিজ্ঞেস করবে how will you syringe it? কেউ বলতে পারবে? Syringing of the ear. ডিরেকশনটা বলো। posterior superior, out of the deep part of the canal. deep part এ ঢোকালে কি হবে? না না, আমি posterior superior দিচ্ছি। if you go more inside, touching the bony canal, what happened? Injury of the canal skin, because deep part of the skin, bony part of the skin and cartilage part of the skin are totally different. পড়ে নেবে কেন ইঞ্জুরি হয়, কুইক ইঞ্জুরি হয় সেটা পড়ে নেবে। দ্যাট ইজ নো, skin is directly adherent to the bone and very thin skin. Right? Complication of syringing, perforation, trauma, bleeding, তারপরে এগুলো কমন বলে দেবে, কমন জিনিস। আর যেগুলো বলতে পারবে না আন্দাজে সেটা হচ্ছে ভেসোভেগাল অ্যাটাক, আলনন লাভ। সে তো প্রাথমিক যখন জিজ্ঞেস করবে তখন বলবে হাউ ভেসোভেগাল অ্যাটাক অকার্স, জিজ্ঞেস করলে বলতে হবে। আর কি হতে পারে? টেম্পারেচার অফ দি ওয়াটার টেকেন বাই দি সিরিঞ্জ। সিরিঞ্জ কি দিয়ে করবে? জল দিয়ে করবে তো। জলের টেম্পারেচার কত হওয়া উচিত? বডি টেম্পারেচার 37। ইফ ইট ইজ লেস তাহলে কি হবে? হ্যাঁ, ক্যালোরিক স্টিমুলেশন। হোয়াট ইজ ক্যালোরিক স্টিমুলেশন? হ্যাঁ, caloric stimulation হচ্ছে thermal stimulation of the perilymph of the lateral semicircular canal. lateral semicircular কোথায় থাকে? there is elevation medial wall of the middle ear, inferomedial wall of the auriculus addentrum, ওইখানে থাকে ইমপ্রেশনটা। সুপিরিয়র থাকে না, সুপিরিয়র থাকে superior semicircular canal। পড়েছো ইনার ইয়ার অ্যানাটমি পড়েছো? হ্যাঁ, কটা ক্যানাল থাকে? সুপিরিয়র, পোস্টেরিয়র, ল্যাটারাল। ল্যাটারাল is the more superficial and there is stimulation of the perilymph। থার্মাল স্টিমুলেশন হলে কি হবে? ক্যালোরিক টেস্ট পড়েছো? ক্যালোরিক টেস্ট, হ্যাঁ ওটা ক্যালোরিক টেস্ট পড়বে। ভার্টিগো, তাহলে কি হবে? ভেসোভেগাল হবে, ভার্টিগো হবে, ইঞ্জুরি হবে, এগুলো মনে রাখতে হবে। এই দুটো মানে আন্দাজে পারবে না বলতে, বাকিগুলো সব বলে দেবে। ট্রমা হবে, হিমারেজ হবে, পারফোরেশন হবে, কোনো অসুবিধা নেই।